Go through this component. We know about the various spinal nerves that exist. I'm a little bit behind, I'm noticing, so I need to pick up speed a little bit. Go ahead. What have I got? 8? I think there was 7. Yeah. Okay, whatever. Oh, not me, baby. We know what the spinal anatomy looks like, so any damage to any component of this, especially in the range of 3 through 5 cervical vertebrae, you run the risk of having phrenic nerve involvement and paralysis secondary to that. Let me make sure I got this turned on. So yeah, fractures above C3, typically you don't see because they don't live. C1 is considered the Hayman's fracture, so if that snaps, then it's sayonara, and there's no discussion beyond that. I have seen some C2s, and C2 would be basically the patient be able to blink, and Norman, I remember him well. That's how he would get your attention. That's all he could do. He couldn't move the arms, legs, shoulders, nothing. So they're very high. Those are the folks who are going to be on the ventilator on a permanent basis. Your Christopher Reeves kind of a picture. I don't know where his was, but I know it was pretty high. C3 through C8, you can have some function of respiratory muscles, especially starting getting down. C5, C6, that they may just need nighttime ventilation, kind of what we used to call recharging the motor, or recharge the battery as you go. And below C8, really talking more about abdominal muscles and looking at problems with bowel incontinence and urinary incontinence, and not really as much from our standpoint, although they may have have the need for bronchial hygiene, which I think is all around the room here, if I'm not incorrect. Okay, let's talk about amyotrophic lateral sclerosis, or ALS. Of all the ways that I would not want to die, this is probably in my top 5, because it's just a horrendous way to go, because the cognitive function is totally there, and it's just a loss of function. It's also known as Lou Gehrig's disease, and it affects the anterior horn cells, whatever the hell they are. But basically, you end up having weaknesses that occurs in the hands and feet, and gradually it progresses to loss of the ability to speak and swallow, and you end up not having a problem with the sensory component. It's all motor. So you feel pain, but there's no ability to move. Usually, they die, 50% die within 3 years of onset. It's a rapidly progressing weakness that ends up happening to the point where it reaches the diaphragm. And there are patients who do choose to go on a ventilator long term, but it's that long term is not very long in most cases. Affects all ages, all ethnicities, all ages. Not pretty, but it's one that you end up encountering periodically. If you want to go check out further, you can go to the website there.
I thought it was more common in
Oh, I have. Yeah, oh yeah. You guys like stroke? I don't believe it's genetic. Now let me rephrase it. There is some familial association, but I don't know that it's necessarily transmitted in the genes to something in your genes. If that makes any sense. Yeah, that's a joke. I just did 930 set up will proceed approximately 930. Yeah. Okay, let's continue on with sleep disorders then. I think we need a movie first, right? Okay. We're gonna change this. See if I can get it to go this way. Cited for speeding was the reason why I was stopping to begin with for going 55 and 40. You also can be cited not moving for a stereo loud audible over 25 feet away. You just sign there for the speed, please. Liar. That's not the idea. Listen to rock and roll, or listen to rap. Go right. I'm not sure why you think a police officer is going to come help you get ice off your windshield. I don't have like anything to get it off with. I can't scratch it off. Okay. If you don't have an ice picker, you're going to have to use something else with an edge on it that you can get it off, or start your car and put the defroster on for a while. All right. Well, can you all help me here now? I'm helping you by giving you suggestions. All right. Later. I locked my car, my battery shut down. You locked your car? The power shut down my car. I was starting to have to go out and starting to freak out. And then you took the battery down? Yes. Okay, you tried the handle while you had it. No, ma'am, it won't let me do anything. Can you actually see the top of your lock? You know, on the door, can you see? Oh my God. Wait, please. Concentrate on watching. And here's the interception. A little unsure of where it goes. Watch, there we go. Okay, there we go, the circle. There we go. The cops coming out. What's your emergency? I'm watching a movie and I gotta see another guy with it. I'm ready to be out of my blockbuster. Okay, what do you want me to do about that? What do you want me? What can you do? There's nothing we can do. If you don't want to watch the movie, then turn it off. You wonder sometimes, can you really be that stupid? All right, oh, I didn't activate it. Hold on. By the way, this is Guy Beret, just so you know. Well, you chose correctly. You chose wisely. Just give Bill a chance to get his own. Come on, come on, come on. I don't know why either. Why am I so far behind?
Because we're waiting for things like this.
All righty. You know this is ALS. Very good. Very good. Wonderful job. Ten. That was not good. Come on. Come would have to see the answers, wouldn't it? Oh, so long ago. You didn't teach us this. Ooh, that's not pretty. Tensilon is the correct answer. It's a smoothball question. Sure, why not? Could be. Is anybody not going to the seminar? You're all going. Okay. For at least one day. It is at Drafonium. That is correct. Amy, smoking. No, it was last year. Okay, types of apnea. Sleep disorders. There's really two primary kinds, and then there's a mixture of the two. But obstructive is probably the more common type that you'll encounter. It wasn't really until relatively recently that we started noting that patients with sleep disorders is a disease in and of itself. The definition of sleep apnea is whenever you have a period of 10 seconds or longer of apnea, and it occurs at more than 5 per hour. Okay? When you have a significant disorder, they're far more frequent than that, and the apneas can last for a prolonged period of time. We had one guy that had come into the sleep lab, and he had 45 apneic periods per hour, some lasting as long as 45 seconds. So when are you breathing? um,
My husband just, it's funny, we were talking about this, he just went for a run, he just got the results today, and he told me that they told him he has, on average, 113 episodes an hour.
yep.
Wow. That's true.
Life insurance.
I have timed them, I've got my phone out, it times how long, but I'm sleeping.
Contrast that with what is called a hypopnea. And a hypopnea is basically where the rate and depth go down, but you don't actually have an apneic period of longer than 10 seconds. Together, they're called the respiratory disturbance index, where basically we count the number of these two events that occur during the sleep, and we divide by number of hours. But if you're seeing 10 to 15 events per hour, that is considered significant. So that is considered significant. What causes the obstructive apnea is literally an obstruction, and it's usually the upper airway, specifically the tongue that falls back and creates an airway obstruction in the process. There are 6 stages of sleep, one of which is wakefulness. Doesn't sound like that should be a part of the stage of sleep, but it's classified as such. Then there are 4 that are non-REM states, where REM stands for rapid eye movement. And this is basically a quiet or a slow sleep wave. And the way we determine the staging of sleep is by doing an EEG on the person. And then there's also, yes?
Is there 5 stages?
6.
You have 5 on it.
Yes, it should be 6, because wakefulness technically is considered a stage of sleep. I know that sounds weird. But when you go to sleep, there's a point in time where you're awake, and then you gradually go into the various stages in the process. REM is the stage where you end up having active or where the most dreams occur is in that REM sleep. And it's called REM simply because you do have eyeball movement that occurs. All other skeletal muscles are paralyzed except for your diaphragm and your heart, obviously. But your eyeballs move. So what we look for to categorize these stages of sleep are a couple of different things. We talked about the EEG being one of them. There's a change in the frequency and the amplitude of the waves that your brain creates. And there's a pattern to it. And you can, as a sleep technician, which a lot of respiratory therapists go that route. They want to watch people sleep all night. Okay. We also look at the electrocardiograph, your eyeball movement, electromyograph, looking at peripheral limb movement, positions, any behaviors that are occurring during sleep, and then also breathing patterns, specifically the apnea. We talked about non-REM sleep. It is basically progressively going down. And what's interesting is it's not something where we go from stage 1 to stage 2 to stage 3 to stage 4 to REM. We go stage 1 to stage 2 to stage 1 to stage 2 to stage 3 to stage 1 to stage. It goes back and forth in the process. The REM is the important component because that's where we start seeing a lot of the alterations in ventilatory patterns. Your breathing no longer is as regular, and this is where the majority of the apneas and the hypopneas occur. All of us have some desaturation that occurs. I'm guessing if he's having that many, he's having a lot of desaturations. You should put a pulse ox on. Has he had a sleep study? So it'll say in there to what extent, because it's one of the things they obviously monitor. There you go. There you go. But basically about a quarter to a fifth of your time is spent in REM. The problem with REM, again, is that you have paralysis of all the peripheral muscles, including the tongue. So that's why the apneic periods occur during REM sleep. And again, we talked about dreaming being most vivid, and the paralysis of all the peripheral muscles, including the outer airway. This is the time when also the deepest of sleep is most difficult to awaken, or if you awaken from you're not always conscious that you're fully awake in the process. Lots of other sleep disorders that are there, narcolepsy, where the person has the ability to fall asleep in a very quick point in time. Usually it's 15 to 20 minutes that you're going from wakefulness to stage one and kind of floating in and out. These people go from wake to sleep within minutes. In fact, they're so bad in some cases that they'll fall asleep in the middle of the sentence, wake up, and continue like nothing ever happened. Yeah. Correct. Correct. Yep. Yep. There have been cases. We had one guy who was a bus driver with narcolepsy. Yikes. Yeah. Yeah. Parasomnias are just some other altered sleep states. There's a restless leg syndrome, or in severe cases, leg cramps. And there have been cases where people, the wife comes into the ER because she's all battered up, and the husband was hitting her at night, but he was asleep, and he just happened to have that kind of a thing where he kicked her. Huh? No, that's just the restless leg, or you can end up having all kind of problems with that. But we're going to focus mainly on sleep apnea. Polysomnography is the study that is done. It's typically done in a sleep clinic. May or may not be within the hospital. In most cases, they're off-site or in a nearby building. They're usually just monitoring somebody over a course of an evening's sleep. And we know about all the monitors that are there. And again, they're often videotaped also so that we can tell body position. Yep. The home ones are being reimbursed. There's a question as to how, and the reason why they're doing them at home is because the backlog to getting into a clinic is so great. The problem is that if you got somebody who's got really pronounced apnea and you're documenting it, and they go into cardiac arrest or whatever, there's issues associated there. We're monitoring with a nasal sensor the respiratory rate. We're looking at using bands, using inductive plethysmography, so they're like lightweight belts that go around the abdomen and the chest wall to tell if there's chest wall movement. We're looking at EEG, EOG, ECG, any other kind of G. Throw that in too. And you're literally wired for sound. We opened up the sleep lab when I was working at Bon Secours back in the day. I actually volunteered to have a test done, and you wouldn't think you'd be able to sleep with all these wires and everything else attached, but you actually do. And it may not be the most restful of sleep, but you are able to do it. Yeah, that's about the height of it. So the individual is going to look at the various waveforms and be able to tell what stage of sleep that they're in. Here's the inductive plethysmography, which basically is looking for pressure changes either in the chest wall or the abdomen to determine if they're moving or not. There's the sensor on the leg.
Do they give any kind of mild sedative?
No, usually not. No. Because the sedative is going to alter your sleep pattern, and we want to see what the normal is. So here it's picking up on the leg kicking. Is there? And what we do is, again, total up the apneas and hypopneas that occur during the night, divided by the number of hours, so we get a respiratory disturbance index. Okay. And we also, I want to identify those periods where they desaturate. Okay.
With the hypopneas and the apneas happen, is there a time when they don't happen in the same study?
Nah, usually you have both.
Okay.
Yeah, it's pretty common. Add the number of apneas and hypopneas and divide by the number of hours of sleep.
Sure.
It's a real tough one. When we talked about some of the problems that you end up having, workplace accidents along with motor vehicle accidents, alterations in job performance, um, family discord, decreased quality of life. There was the one guy was talking about that had all the apneas and whatnot. His snoring was so bad that she slept in the basement and he slept in the attic and he still kept her up. It was that loud. And she insisted that he go get a sleep study done. She was ready to divorce him because he was such a jerk. And got the sleep study done, got it treated, and actually his whole personality changed. But lack of sleep, which is what you have if you're having all these apneas, is obviously going to play into your personality and your ability to do that. Obstruction is the most common. It can be partial or complete, and this is where we're going to monitor the airflow and look at the chest wall and abdominal movement. So with obstructive apnea, you end up having chest wall and abdominal attempts to breathe, but there's no airflow. Okay? So it's the key part is that they're visual guys doing that and nothing's happening. Okay? And because of that, they drastically desaturate more than the central that we'll end up seeing. Because there's obviously all the effort that is being generated attempting to take a breath. And it can develop not only cor pulmonale, it can develop into congestive heart failure and a bunch of other diseases. Obviously, if you're desaturating that much, you're at high risk for all kind of other problems like myocardial infarction. John Candy, you guys remember John Candy? Fabulous actor. He died of a heart attack. No, he died of obstructive sleep apnea. I have no doubt in my mind the man was obstructive sleep apnea. Good God, he was huge. But again, respiratory effort, abdominal effort, apnea. That's obstructive. Contrast that with central apnea where there's neither chest wall movement nor airflow. Central apnea is caused more from the respiratory centers not operating appropriately. I think they talked about some of the kids at camp have central congenital hypoventilation syndrome, where when they go to sleep, they profoundly hypoventilate to the extent that they can actually go apneic. That's, again, central in the process. And they're just ventilated at night, and during the day, they're fine. One of the girls actually got a diaphragmatic pacer put in. I don't know how that all worked out or not, but just like you can pace the heart, you can pace the diaphragm. Some of the symptoms of obstructive sleep apnea, Teresa, I don't know if you can check these off as we go through. Habitual snoring, gasping, and they wake themselves up. The snoring is so bad and the obstruction is so bad that they get to the point where they literally wake themselves up. Okay. Morning headaches, because you're not getting adequate sleep, you end up with headaches. Daytime sleepiness, again, falling asleep in inappropriate places. Often they're obese, but they don't have to be. And it's kind of an important point to remember. They're not all John Candies. The guy I described was actually very thin, but he just happened to have some tissues in. Often they're hypertensive. They can have nocturnal enuresis, meaning wetting the bed that they're not even aware of. Don't want to go there. And we'll skip the impotence, too, as far as knowing anything like a lady going on there. And it's usually the bed partner that has the best descriptions of what's going on, because they're totally unaware of it. So we interview someone for a sleep study. Often we have the bed partner come participate in the evaluation. Well, alcohol makes it worse. Upper body obesity, large neck size. Again, the presence of hypertension and the complaint of daytime sleepiness or not getting a good night's sleep. There's a special type of obstructive apnea called Pickwickian syndrome that is associated with a chronic ventilatory failure, morbid obesity, and sleep apnea. Again, central is where it's something to do with the respiratory centers within the medulla oblongata. They're not sending out the signals like they're supposed to, so you end up having both cessation of airflow and no chest wall or abdominal movement. Okay, and they're less common in the process compared to obstructive. And then, as always, you can have a little bit of both. Sometimes individuals with Down syndrome often have this simply because of the neurological and physical enlargements of the neck. And Pickwickian is really I guess I would classify it as mixed, yes. So there's the mix. You can see there's some portions there where they're having total apnea and no muscle movement, and then there's some muscle movement, but it's still apnea. And hypopnea would just be a reduction in the flow and volume that you end up seeing. And there's all three of them kind of together to give you an idea. Again, hypopnea is just the reduction in rate of breathing. And there's other screws we end up doing, including some pulmonary function tests. But it's really the sleep study that is utilized to diagnose and to treat obstructive sleep apnea. I don't know why I have that there. Other things that can be done if they are obese, doing a weight reduction program, although that again doesn't necessarily have a factor. Alcohol and smoking seem to have worsening of the symptoms. The position they sleep in, there's been attempts to try and keep them off their back by sewing tennis balls into their pajama tops. So when they lie on their back, it's painful and they roll onto their side. Okay. Sometimes it's treated with oxygen at night. The saturations are significant. Some oral appliances do help keep the mandible pulled forward. But really, I'll get to good, but there's one type of therapy that is there as far as surgical stuff. Laser-assisted uvulopalatoplasty. Basically, the rotor would really go in there and move the uvula, the palatine tonsils, all those structures to try and reduce the amount of space that they end up having. There's other stuff that can be done also. Even worse comes to worse, the tracheotomy. One guy was talking about that had this long period. I would, although had a 40-second period of ventricular standstill. Just B-waves. He was trached next morning. Here's what you're as far as the oral cavity. We're talking about all of this being surgically adjusted. Most commonly what we end up using is nasal CPAP. That is probably the best therapy for it. What we're doing is applying some positive pressure to the nasopharynx and oral pharynx, and in the process then keeping that area patent. BiPAP, which is basically two pressures, is used less commonly, although for central apnea certainly can end up using some kind of alternative ventilation. Some of them are on BiPAP, some of them are on other types of negative pressure ventilation. That's what the NPV stands for, where like an iron lung, where you're creating a negative pressure outside the thoracic cage to pull the cage open. There's various ways to do that. We'll talk about them over the summer. There are some REM inhibitors that can be done to limit the time in REM, because again, that's the point in time where most of these episodes occur. And we talked about a phrenic pacemaker for central apnea. But what is done with nasal CPAP is just basically you're applying some positive pressure to the nasal cavity. And that's enough to keep the tongue off the posterior pharynx, reduce the amount of obstructive element that is there, and sleep can go on. And everybody's happy. Yes, this is true. But we have a strap. We have a strap for that. A chin strap. Mm-hmm. This is nasal pillows where instead of using a mask, they're just little small pillows that fit inside your nares. There's a nasal mask, full face mask. No. Amazingly, let me just stop this here for a second.